We move back from the north to the south of the country for our third and final speaker. I'd like to invite Graham Webb, who's the Quality Coordinator of Child Health from Canterbury DHB, to talk about their experience.
Afternoon, everybody. Just want to clarify that I'm not the Graham, the 57-year-old that my colleagues from Southern Cross were referring to. Hopefully I'm a little bit younger than that. Okay. We have a why we want to do this, and it started long before we approached the Health Quality and Safety Commission about being involved in this pilot. And it was all about a baby who unfortunately had 2 overdoses of morphine, of which Mum kept on saying, there's something wrong with the breathing, there's something wrong with the breathing, and nobody picked up on that. There was intervention going on, but we weren't listening to what Mum was telling us about things are changing. Oh, it's probably because they're not feeding. There were all these other things, so they were getting NG tubes and all these other things, and then unfortunately the child got to the point where they needed respiratory support and transferred to ICU. And that's when we found out that there was an adverse event that occurred. I guess the other adverse event within the adverse event was the fact that we didn't listen to Mum's concerns and actually explore them right through to a resolution point. Okay. So, yeah, patient harm occurred. So I just want to change tact a little bit. Alex mentioned have a preconceived notion when he started to introduce this, and we were guilty of that, and I guess I'm guilty of driving that within our DHB to start with. And I asked the question, is it really better to have a really good knowledge of family escalation and the literature and systems around that when you enter this process, yes or no? Okay, I would say yes and no. The reason why I say yes is because all of that information is really critical for you to approach and engage with your clinician groups and talking to them about the fact that, okay, whatever's been done overseas in terms of 0800 numbers or whatever the upper echelon is in terms of the patient getting help or their second opinion does not lead to major workload increases and all those things. So it's good to have that body of knowledge so you can start to go out there and pitch the idea, pitch the thought. But it also may give us the preconceived notion that, oh, here's our solution, we just need to implement the number and everything's going to be fine. Well, I guess our journey was that as we started going through the co-design process, that in actual fact, we found that there was things that were foundational here that needed to change. We needed to change the way that we communicate. We needed to have that better rapport, that relationship, and listen of what people are telling us. And that doesn't mean to say what I'm talking about today is that, oh, nobody in the CDHB listens to patients. That's not the case. For the most part, they do. But we found a few cases where that was not the case. So our journey started, there was a lot of discussion in that engagement phase. We went to directors of nursing and we went to chiefs and chairs like medical staff, etc., etc. Went through that whole process, talked about the literature. There was some ums and ahs because, you know, as a lot of you may know, most of the literature or a lot of the literature is all paediatric focused. So they were happy for us to do something within paediatrics, but not necessarily convinced that we should do something in adults, even though that it seems like it's fairly straightforward. It's just about talking to people and listening and using that information, because isn't that what we do anyway? We take a history. Yeah, we do that still, don't we? So part of that is that, okay, we shouldn't stop listening to the patient or the family at the point where we've finished taking the history. It's a continuum. We should be continually listening to them. They're the ones who know the norms of that particular individual. So if those norms start to become deviated or different, then we should be listening to them. So what we also needed to do is we just wanted to make sure that there wasn't something out there already, because none of us really knew. So we had to do a little of exploratory work. There wasn't really anything other than the call bell thing, which we also did like Waitemata in terms of the Health Quality and Safety Commission gave us a tool to explore that, and we did that. But we also discovered this poster, and it may or may not be clear to you, but this was scattered around lots of places, lots of places. What I mean by that is around elevator shafts or elevator lifts, and nobody really saw it. So certainly a lot of people from our paediatric team, except for one registrar, actually knew it existed. And not only that, we started to dig a little bit deeper to get an understanding, well, is anybody logging those calls and the nature of the calls and who they're being diverted to and all that? No. So while this poster is there, I feel that it was certainly token as opposed to it actually was put into a feedback process, a learning process, and we could actually learn from those calls and get an understanding of how we could improve. Instead, we've basically left that up to our complaints process. So yes, we did some data collection, and part of that was looking at complaints data as well as compliments, okay? We sifted through electronically looking for kind of keywords, some criteria around, people multiply presenting several times, saying that they weren't being listened to, looking for things like that, which then we pulled out 15 of those complaints. Okay, there were no informal complaints that we could find met that criteria, but we found 15 that did, and started to go through the entire complaint and to get an understanding of what the themes were. Okay. And lo and behold, what was it? They didn't feel they were being listened to, okay? And then the other themes that came through fairly strongly as well was they were feeling unsupported, and the information that they had, valuable information to us as clinicians, was not being valued. And that to me was actually quite astounding. The other thing that obviously we wanted to do is we didn't want to have a negative focus on this. We actually wanted to look at compliments as well. We didn't really find too much other than the fact that everybody is very thankful for the work that we do, okay? But we do have an example as we started going through the co-design process for about one particular story that I'll tell you a little bit about in a minute. So we did a lot of one-on-one stuff with consumers. So we decided that we were going to do this in an 8-bedded paediatric progressive care high dependency unit. One, because we thought, well, that's where our most sickest children are, and that's where we might see a higher level of anxiety of parents about them being concerned and so forth. So we thought, well, that may be the best place for us to start asking a whole bunch of questions. So this took us a long time to figure out what are the right questions to ask to get the information that we need to get an understanding of what's going on. So we asked this, and through doing that process and also the call bell process that Waitemata outlined before, we came across this particular mum and her story about her daughter, her non-verbal daughter, who got admitted to hospital, and basically mum said she was in pain and tried to convince people for 8 hours that she was in pain, and no one would listen to her, and she did not have any pain relief for 8 hours. And so this is how she described the situation. She felt like she had to leave the hospital and come back in through the system again to get what she needed. She didn't though. She persevered, kept on going. Finally, a consultant who came in the morning, who knew the patient, who knew mum, valued the information that she knew about her daughter, and then went ahead and pain relief was prescribed. But that is really a shameful situation, is it not? The positive story that came through was another mother described how their son or daughter came through to ED, and basically from get-go that the nursing staff and the physicians were engaging with that particular parent was really basically just continually telling them that what you tell me is really important. I value that, okay? So that message was was right there from the very beginning. And that was one of their most positive experiences. And so a lot of those behaviours and those attributes, we tried to make sure that in the re-engagement process and re-education of people, that we said that this is what they want, this is what they're looking for. So overall themes of consumers, which you already looked at from the complaint data, we started to see obviously they're not listening, that clinicians weren't listening, they felt that their information wasn't being believed. So we had kind of two streams. We had what we called naive hospital users, I guess, so it might have been the first time that their son or daughter was hospitalised, or it may have been a situation that they were one of these chronic users of the system. And obviously the chronic users of the system, because they'd been longer exposed, they had good experiences and they had not so good experiences. And so we were able to glean a lot of good information from that particular group. Okay. Interesting enough, you'll see down below that one of the other sites also talked about staff busyness and that being a barrier for people to raise concerns. We also saw that. So capturing staff experience, yes, we had some focus groups with some clinicians, our SMOs, our registrars, house officers, as well as some nursing staff across paediatrics. We asked more than these things, and one of our focal points was asking about the language that they use and the engagement process that they have with those families. We're really quite interested in that. And when we put to them what the families were kind of telling us is that they want to be invited to express their concerns, they said, well, we ask if you've got any questions. And we found that they were two completely different things from a consumer perspective. Okay. One of the other things that we did that I haven't got on that slide is that we definitely wanted to check if they themselves, any of the clinical staff, had a family member or themselves been in that situation where they've been in hospital and they'd felt concerned that they'd tried to raise concerns and what challenges and barriers, so we could get them to walk in the consumer's shoes. So overall, we felt that even though we couldn't map like some of the other pilot sites were able to do to particular parts of the journey, we felt that this was the theme, that it didn't matter what was happening, that at any point in the journey, if you don't get the communication right, it's all going to fall apart, okay? If we're not welcoming, if we're not inviting the concerns, then we're missing an opportunity. So we got together and basically thought, well, what does the solution need to look like? So up there you can see that consumers want to be heard, they want their information to be valued, that they expect the clinicians to have experience and knowledge but acknowledge when they don't. That was a really big thing, that essentially they really want that honesty, that, okay, sorry, we don't know right now, we need to go away and find out more information. So this is what kind of shaped our solution, I guess, which ended up being a conversational prompt, which a lot of people might have thought to start with, we're telling people to suck eggs. All right, but at the very beginning, we kept on saying, we know that you do all this stuff, but what we're asking you to change slightly is just to tease out, do you have any concerns or specific concerns about the condition of your child? Can you tell me more about that? I really would like to know about that. Okay, so encouraging that communication. And then encouraging it at any time, that even if we look busy, call the bell, okay? So we were asking the clinicians to, pretty much do this at the admission point, at handovers, at bedside handovers, at ward rounds, at any interaction point, like physician review, stuff like that. We had one particular parent who unfortunately didn't get the information about what we're trying to do and was a little worried about the fact we were asking her, are you concerned about anything all the time? And it wasn't like it was a broken record, like we were doing it all the time, but essentially they ended up asking us why. Okay. So as you can see, that was the part down the bottom where we were just getting them to do the call bell thing. This was an actual mother who took, because we felt like we just didn't need the conversational prompt, we needed to provide context to the parents. So we felt there was a handout required, and we really had a 50-50 uptake of this, okay? So essentially some people felt like this was really good. In fact, one mother who was not a naive user of the hospital but been coming to the hospital for ages said to us that if I had this when I first came in with my son, this would have been fantastic, okay? This particular mother thought, who was an early education teacher, I have to say, felt like there's too many words, we need to fix it, and so it's gone through a couple of changes since then. One particular mother said, you don't need this, it's all about the conversation. That mother loved the fact that a nurse spent time with them at the admission point going through, we really want to listen to your concerns, this is how you do it, etc., etc. Okay? And in fact, she was so happy about that whole conversation, she provided a compliment through to the general manager of the division. So basically, we learned a couple of things, and I'm running out of time here. And what the staff felt like, it was easy to use. It was very easy just to drop it into the conversation, and that there was no real barriers there. What a lot of them found is that it actually gave them self-awareness about the language that they were using in those interactions. They actually felt that they were becoming more aware of not just the child's needs, but the parents' needs as well, because they were learning of certain things that they may not have learnt about if they hadn't asked that question. And then one of the other things that we did, apart from those one-on-one things, is we did some shadowing, and we were watching the clinicians use the conversational tool, okay? And then we would go back and ask the parents what their feelings were, if they felt confident, that knowing that we were inviting those concerns. And for the most part, they did. Okay. We didn't have a very good kind of compliance of handing out the leaflet, and the leaflet we also doubled as a poster, because we asked clinicians did they want like lanyard cards or something like that to help them. They said no. If the poster's on the wall, then that will be our prompt. Okay. This is what one mother said about the tool and about being asked about concerns. So where to next, just quickly. We're trying to implement the number, believe it or not, okay, but we understand that is the ambulance at the bottom of the cliff, and we're still working on the foundational things. So that's our next iteration of the parent handout, and that's the poster that's going on the walls to enable the parents to contact us. We're putting a prompt into our observation chart to record parent concern, and we are in the process of talking about, do we actually put this in our patient boards, okay? Rather than it becomes a separate thing, the patient board is actually quite popular in our child health areas and has become a focal point, so we're wondering, should we start to try and incorporate the information into there? Okay. Just some quick acknowledgements. We have some of our team here today. We have Dr. Neil Davison here. In fact, the 0800 number at one point was going to be 0800 call Neil, but he wasn't real keen about that, I have to say. And we have Rosalie Waghorn from the West Coast is also part of our group. Okay. And most importantly, we have Mr. Rob Earle here as well, who is one of our consumer reps. And the whole experience of the co-design with these guys has been fantastic. We've learnt a great deal from them. It's been really good. Thank you.
Thank you very much to all three speakers. We have about 5 minutes if there are any questions from the room. If anyone wants to ask any of our three DHBs about their experiences and anything that you may want to ask us as program drivers about what we can do to help you, now is your chance. Or you can just come and find us informally afterwards if you don't want to put your hand up. But Emma has a mic at the back and is roaming. Anyone have any questions?
What if your consumer counsel says you don't need
Has yours said that? Yes. I would suggest you get a new consumer counsel. I mean, do you think that's a reasonable thing to say? I don't. The consumer's usually right, but in that situation, I mean, you know the clinical situation in your hospital. There is evidence behind this process. So far, the 3 DHBs who've implemented it, they seem to have strongly positive experiences from the feedback so far. I would probably explore why your consumer counsel thinks you don't need one. They probably think you're doing a better job than you think you are, which is great, and there isn't a communication problem. But maybe that's not the case.
And I don't understand half of what is said in all of this, and it's awesome to be here, and thank you very much to the Health Quality and Safety Commission. Can I just address that? Who are your consumers? And what was your selection process? And if you only pick people who write compliments and tell you what a great job you're doing, then that's a problem. Because if your consumers are only people who have had a successful experience in your hospital or through your care, then you are not addressing the problems, you are addressing the successes, and that's not what it's all about. So I just want to say that. Thank you. Oh, and also, moving on, because I've got another question. Before November 2017, was there not a national early warning score kind of system in New Zealand healthcare?
The answer to that will be given at 10:50 a.m. tomorrow. But the essential answer is no, there wasn't a national process. We all did our own thing. Were there any other questions? Great. Well, rather than stand... Oh, no, sorry, in the corner. There's a question. Hi, Heather. You don't need to introduce yourself.
Actually, sorry. Is that going? Actually, Jen, why don't you tell them the reasoning from the consumer group?
I think it was better from... It's something to do with the amount of noise from the posters that we had in the hospital. So there was two things. There was, from what my understanding... Oh, gosh, here we go. I'll get on a mic. So my understanding was that there was two things. There was the amount of noise that was coming from posters, because we have a lot of posters everywhere at Nelson Marlborough. And the other thing was that there was a thought that the patient relationship with the nurse should be as good as the person actually able to escalate to the nurse, and that having an external line would actually diminish that relationship. So, interesting.
And that's probably something the clinical staff feel as well, is that having someone else to bypass you may affect the relationship you have with the person in front of you. But it's an identified problem, and if there wasn't a problem, we wouldn't need a solution to it. We know that, that's why we're here, but I feel like I'm teaching out a second. Sounds good. Right, oh, sorry, yes.
I think it's me, if I can just say something quickly. As the Consumer Engagement Advisor for this Kōrero Mai, I think it's perfectly reasonable that consumers should say, well, we're not entirely sure, because I think as Graham and I had many hours of conversation, clinical people aren't sure either. So it's just a way of asking some very good questions about what will this do to our relationship when we come into hospitals. And I have offered to go and talk to that consumer group, and I look forward to doing so.
Neil.
I just wanted to ask if we've... one of my concerns with Kōrero Mai was if we nationalised the chart, is there any benefit or scope in nationalising the Talk to Me programme in terms of the end result of the programme? Conscious that in other states in Australia there's often a statewide number to ring, from my understanding, or in other countries. Is there any benefit from having a national number so that the cognitive bias of a poor institutional strategy doesn't come through in the response?
I think I'll get Laura to answer that probably, but I'll just give my opinion first. I think technically that would be difficult. From a funding perspective, having a single number you could ring wherever you are in New Zealand that diverts to the local person in your hospital who's on call at that time to answer that question would be difficult, unless we're going to set up a Kōrero Mai call centre somewhere in the same way the ambulance has a central comms. So I don't think that's physically possible. We've also realised that the response needs to be determined by each DHB that's appropriate for them, and therefore needs to be designed by them for their system. No one knows what works better in your hospital than those of you who work there, and certainly me sat in the Commission in Wellington telling you this is how you do this is not going to work. So I think ideally, yes, it would be great to have a single number that you could do that from, but practically I don't think that's possible. Laura, what do you think?
Well, basically what Alex said, but I think the point of co-design is that it allows each hospital to look at its local population, to devise a system that meets its local population, particularly I think when we look at our Māori Pacific populations. And what we're noticing from the first lots through is that there are great similarities but also significant differences, and I think we need to have a system that works in that way. Oh, but I have to say, we don't just pretend to forget everything we've learned from the first lot through. We share that with the second lot through. So it's not as if we're saying reinvent the wheel. We're saying these are the things we're learning about how populations experience escalation. Learn from that, but please check out with your own populations as well.
Any other questions? Right, so just to say, the three DHBs you've heard from, three organisations I should say, sorry, I'm lumping Southern Cross in as a DHB, have all written their case studies up and they're available on the HQSC website. So if you wanted more information, obviously you can talk to the people who are here today, but also they're on the website and available, they're free for all. So we break for lunch now at 1 o'clock. A few housekeeping things. This room will be divided in two, and we have two workshops here this afternoon, which some of you have expressed a preference for. Workshop 1 is from my colleague Carl, who I think is off writing his talk at the moment and not in the room. He is talking about resilience, it's not you, the system. And those in workshop 2 are being scoped and taught how to have expert communication skills around deteriorating patients by Jonathan and Anne, two palliative care consultants. If you look at your badge, you'll see you have W1 for Carl or W2 for Jonathan and Anne written on it. We'd also like you to remove your bags from this room if you have any in here so we can split the room and make them separate. And please come back at 2 o'clock sated. Thank you very much.